Thank you so very much, and thanks to Pawan, thanks to Sanjay, and thanks to the team of Protocon for having asked me to come and speak. It was wonderful to listen to Dr. Uman Nambiar giving a context about what this hospital is going to be, and then I'm going to tell you that the Primer Group has been doing meetings with ADA and IDA for almost 12 years, and this year we have decided we'll be doing it with IAC. That's on the August 9th and 10th. And basically, it's going to be on translational research, and you'll be hearing more about it over a period of time. So, my talk today is about what physicians often miss. Well, I don't know who actually put this particular topic. I don't know whether Sanjay did it or Pavan did it, but if you really ask me, as a physician, physicians never miss. How many physicians are here? I see a lot of hands, and everybody from Diabetic Foot Society, SOGI, and I do see a number of people. I mean, physicians never miss. I show you what physicians don't miss, right? Physicians never miss a miss or the legs. But unfortunately, today we have been talking about diabetic foot infections. So we need to realize this was way back in 2005. Amputation every 30 seconds. And there was no endovascular surgery, and Dr. Suresh also, I think, started his practice as a vascular surgeon almost 35 years back. I started the Icon Hospital about the same time. So this was a fact. I mean, I don't know, we don't have the data today. But what I can tell you today is diabetes care has become a teamwork. It's turning out to be cardiometabolic, renal and vascular in approach. And I've been using this slide for the last 1 to 2 years now. Diabetologist or an endocrinologist is finding it extremely difficult because the treatment is going to be absolutely comprehensive, and you need to have a setup which is going to be comprehensive. And we have very few centers which are actually comprehensive, and this is what you need if you're treating somebody for diabetes today, and then the list goes on and goes on and goes on. So this is where we are today, because a physician is multitasking and trying to handle far too many things at one time. So it is a difficult task for a clinic-based doctor to do everything. But having said that, there's no way one should miss an early infection, because what I see at Icon Hospital is this. I mean, it's worse than this. Even today, it's so sad. Maximum number of admissions are all for infections like this. And our WhatsApp keeps sending messages that somebody has come and then he's got comorbid condition, his anti-pro-BNP is some 1,600, his creatinine is 6, you really want us to admit, and he has no money. Even today, people who end up with this kind of problems are extremely poor, and they would have taken several months before they actually come. So, do physicians miss early diabetic foot infection? I think the answer is yes. They can miss. But I would like to support each one of our doctors and say it's not for want of knowledge in most of the cases. Definitely not for want of knowledge, but it's just that it's not done. Okay, because there's a bit of a negligence, and you tend to take things a little bit more easier. We can actually call it negligence. We should avoid the term negligence because legally it doesn't sound too very good. So it's just not done. It's not done because, you know what happens when a patient takes out his shoe and the socks? It's not going to smell like this flower. This is exactly what happens, and you're in an air-conditioned room, and I'm sure Institute is going to be seeing all this smelly foot, and more of it is going to be coming. And many times a physician is wearing a tie and a suit and things like that, sitting in a corporate hospital, and he assumes that his junior has done the job, but they would have missed it too. So, by neglecting a thorough examination of the feet due to complacency, I think the physicians not only demonstrate a lapse of diligence but also jeopardize their patient's chances of an early intervention for a potentially serious infections, and that can lead to amputations. This is exactly what's happening in India. Becoming too busy. You're so busy. I spent a good amount of time at CMC Vellore before I moved to Chennai to train under Professor Vishwanathan and Dr. Mohan. And even today when I go back to CMC Vellore and then try to sit for some time in the outpatient, the consultant has just enough time to write the sentence, repeat all, or continue the same treatment. And the outpatient goes till about 1 o'clock, 2 o'clock. And it's very sad. I'm sure it's the same at PGI Chandigarh. I'm sure it's the same at All India Institute. The kind of a load that we have to take, I think it is far too much. I think we need to delegate the responsibility. As physicians, we know this is what finally ends up with amputation. So I don't go into the details because all of us already know what happens when there is neuropathy and there is vascular disease. Dr. K.R. Suresh did talk about people going to the temples and places of pilgrimage without their footwear, because it's a religious thing, it's a custom. I don't even wear a footwear at home. And these are some of the things that are very difficult to change in a country like India. That's why I always say Mera Bharat Mahan. But we need to find solutions over a period of time. When you don't take 2 minutes of your time and examine a feet, I think these are the infections that we generally miss. Web space infections, nail bed infections, people walking barefoot have all kinds of fissures, they have fungus infection in the nail bed, paronychia, ingrowing toenail is a major problem. And another thing is, patients hate to pay money to a doctor to get some of these things cleared, because when I tell them that at least use an antifungal powder or a cream or something, they always end up saying, oh, it costs money. Oh, my wife also has it. You know, we all wash clothes and therefore we get it. Okay. So, these are the things. And the blebs. You know, new shoe and then you have a bleb. And these things are often missed when you don't examine them. But when you look at it, this is what I meant by saying, it's not the lack of knowledge for the physicians. It's just that sometimes either the patient does not tell you he has a problem, or you have not examined very clearly because you are far too busy. Normally missed infections, you know, the corn, the callus, all these infections, and the way we actually examine these patients, right? And this is a very, very typical problem when you buy a new footwear. So never wear a footwear with teeth. This is exactly what I tell the patients, right? If you have a bite because of a new footwear, it has teeth, so don't buy it. You know, jokingly we had to tell them many of these things. All that it takes a physician, even a very busy physician or his team, is only about 2 minutes. Remove the shoes, socks, examine the patient, examine all surfaces, examine the nails, web space, identify foot deformities, a quick neurovascular assessment. All that you need is your hands. You don't even require eyes in your hand. You don't really need any of the instruments. The simplest thing is, most of the times in a corporate hospitals, I do see in an endocrinologist's room or a diabetologist's room, they don't have a stool like this. You know, the examination table is loaded with so many papers and things like that, the patient will find it difficult to go onto the examination table. All that you need is a table like this, or probably a table like this, where it becomes easier. So at least a foot examination room must have these two things. Look for signs of infection, inflammation. Just go back to your MBBS days. Suresh did mention about, I just showed the photograph of this great Roman, Aulus Cornelius, who kind of described us the signs of inflammation. You know, the people do talk about a lot of cellular inflammations today. We talk about IL-6, IL-10, IL-8, TNS alpha and things like that, and sometimes forget simple redness, swelling, heat and pain. Okay. Now, the problem we have is we do miss early cellulitis in some of our patients who have dark skin, but at least you can look for the temperature. Oh, I didn't see the redness because this patient's leg is dark. No, this can never be an excuse. Some of the tests, if you have doubtful, simple things. I mean, I don't do HSCRP or ERS, but we can pick it up with the total count when you just do your CBC. These are given in the books, but you don't really have to do this. When in doubt, yes, HSCRP. In fact, ESR becomes the most confusing thing, but anyway, it's a part of the CBC, so we don't have to worry about it. For neuropathic assessment, touch, pain, vibration, temperature. How difficult is this to do these 4 tests? Feel for dorsalis, pedis, posterior tibialis. Use your hands for God's sake. You have learnt it. You don't need to have a Doppler. The fashionable thing today with many of the physicians, diabetologists who have started practicing is to look at ways to monetize how to do a foot examination. I'm very happy some of them are not charging for using the stethoscope today, and I will not be surprised when the day comes. Okay, you're looking at a patient, there's no need to monetize, but it's okay if you want to monetize it. Oh, you'll do an ABI index, you're feeling the pulses so very well. There's no need to do an ABI index at all. If you want to use an X-ray, yes, look for only osteomyelitis changes or fractures or maybe sometimes the shock cuts, but X-ray is not going to be the diagnostic tool for shock cuts. Well, you have neuropathy kits. Some of these infrared non-contact thermometers which we used a lot during COVID may not be very right, but then you can of course use it, but then you have a simple tuning fork and so many other things. Look at this slide where a cigarette lighter has been kept. Please don't do this. For temperature sensation, never do this, because I just thought I should show it many a times. I use it in some patients who come from villages and who have absolutely no temperature sense right up to the knee. I call the family members, I tell them what I am going to do, and sometimes show it to them so that the patient becomes aware of it and then becomes serious about it. Otherwise, this is something that we should never use. These are simple hand Dopplers. Even today, anywhere 14 to 15,000 rupees, you get an ABI also, as Dr. Suresh was saying. You can do it. If you want to monetize, do it. But it's like a stethoscope. I think we must learn to use it. Well, I'll come to this foot mapping and biomechanics part of it. Okay, I'm sure K.R. Suresh also started doing it. We have been doing it for 20, 25 years. I know Sanjay does a lot of it in his clinic. But for some strange reason, I have never been a fan of this foot mapping. Because I realize in our normal people with diabetes, who are not sports persons, this is not going to help, because I have played for the country basketball for 4 years, missed the Olympics, played for the Karnataka state for 15 years, spent a good amount of time in the National Institute of Sports, way back, 75 onwards, and then we have been doing this biomechanics and mapping those days for sportsmen. I'll tell you the problem with it. I'm sure Sanjay also does it basically for this. It's great for sports people, not useful in all your garden variety diabetic patient, because when a patient gains a weight of 5 to 10%, whatever footwear you have given based on the mapping, everything changes because the ground reaction force, potentially causing discomfort or injury. When they put on weight, the gait mechanic changes. I'm sure IASC can really work on something like this. Do we need to give it to all of our patients as specialized footwear, or is it only for sportsmen? There is an increased strain on the muscles and joint, and very interestingly, there is a pressure redistributions with just a little weight gain. Now, our people don't change their footwear. I paid 3 to 4,000 rupees. I would like to use it for life or till the soul goes away, and this is the problem that happens. Men have the habit of carrying big wallets. I'm sure Dr. Suresh and Manohar must be carrying, a very heavy wallet on the right side. Just carrying the wallet in a pocket can have changes like a pelvic and a hip positions. It can actually lead to an uneven gait, potentially causing discomfort over a period of time. And if you are given a specialized footwear based on this, for sports people, yes, mapping, specialized footwear, no way about it. I mean, no questions asked. You have to give it. But a normal person, when you do this mapping, we are going to see changes on the pressure. Okay. And when we see these pressures, there can be some affordable patients who say, okay, I will buy a new footwear, because this 3D printing, new footwear, this is going to be discussed a lot in future. Most importantly, the final part to actually make sure that you don't really miss a DFI, I think, is a foot care education. Videos in your classes, videos that they can download just by a QR code, hand holding and teaching them all about foot care. Every person with diabetes in India probably needs this. And I think every physician must spend a little time talking about foot education, right footwear to wear. I'm sure there'll be a lot of other classes about it. It's not just about working hard when it comes to diabetes management or foot care. It's about working better with a plan. What is necessary for India? What is it that I can do within my thing? Okay. Never look at somebody and try to be that person. Can I be Dr. K.R. Suresh? No, you can't be Dr. K.R. Suresh. Can I be Dr. Sanjay? No. I think each one of us have our own windows. We have our own rooms. So the thing is, you look at your practice pattern and see what best you can do to that, and plan for it and try to develop time. I think it's a team that you need if you're practicing diabetes and if you're serious about it. Now let me come to this important thing, and then this was an eye-opener to me at the IDF 2025 when the recommendations actually came out. And I had a lot of discussions about some of these things. Now what IDF says is, there used to be an optimal care and a basic care. Now IDF is asking a question, the new president is asking a question. Why should there be an optimal care for a rich person, affordable person, and just a basic care for somebody not affordable? Diabetes is diabetes, whether it's affecting a rich person or whether it's affecting a poor person. So now they say, if you can provide, it's going to be optimal care for everybody. So region wise, you decide what you want to give and what your patient can actually afford it. So there is nothing like a basic care, optimal care. Try to give the best care to all your patients. So I'll not go into the details. They have also said HbA1c. I was so very happy when Dr. Umar Nambiar was talking about trying to do a CGM in Bangalore. I mean, with the IASC thing, because they also spoke about CGM for all affordable patients, because that brings in an awareness and they can be checking their own blood glucose from time to time. And it's so expensive. Today we say CGM is fine, okay, for only type 1, we don't need it for type 2, etc., etc. So diabetes care team today will have to have a good foot surgeon, a podiatrist. I've been lucky, I have had a plastic surgeon from day one, and Suresh has been doing an excellent job in Mahavir Jain Hospital, and before that we were together in Malia and things like that. MS Ramaya is doing a good work and things like that. And there are hundreds of students who have passed with Dr. Suresh. I'm sure there'll be a lot of good centers for foot care. And I always tell my interns and those who are doing post-graduation, don't try to look at the surgeon's way of handling things. You're not a surgeon. Okay, simple things, a lot of education, how to take a superficial swab, how to take a deep swab, how to start an empirical antibiotic, without having to wait for the surgeon, how to do the dressing. These are the basic things that we need to learn. So if you want to practice, this is going to be the basic minimum care in diabetes. Well, have a Doppler, have an ECG machine, you have the patient. Train your nurse in basics of podiatry. If you don't have the techniques, I'm sure Dr. Suresh must be doing it, CMC Vellore does it, Karigiri used to do these things. You can train your nurse in simple polio-free, 3 to 4 days. I'm sure IASC can take this up as a challenge tomorrow. You have a dietitian educators, okay, and then you have your EHR. What you don't have, don't meddle. Learn to refer the case. Don't be ever under the impression that, oh, if I refer, the case will not come back to me. Don't even worry about it. The patient is number one to you. If there's a vascular problem, yes, it goes to a vascular surgeon. Don't hold on to the patient, right? And that's the basic minimum care, right? And point of care testing, a lot of things are going to come. It's going to help the doctors. And then we already have this fundus on phone with the AI backed, which has all the three things coming. I think the last 1 or 2 slides, yeah. So this work was done by actually our hospital and my daughter almost 10-14 years ago. You become busy, now what do we do? Can we delegate a good foot examination to your nurse? So we knew what the problem was. At-risk feet had to be identified. The consultants become very busy. Interns may not be very keen on doing it. So we started a simple study, right? The new model is going to be that you pick the nurses, teach them, you pick your residents, and then both will do the things, and then the consultant finally decides. Nurse examines the foot first, it's blinded to the resident, an MD candidate, the resident does the examination, and then the consultant sits. Final decision is that of the consultant. What all do you examine? Now, even today, we would like to bring this back to our postgraduate students. Examine everything. Doesn't take more than 2 to 3 minutes. And then finally, when we presented this, we did the kappa score and things like that. I'll not go into the details of all these statistics here, but the important thing is the nurse and the resident both achieved a 94% accuracy rate with a moderate precision. Now the question is, can we train our paramedical staff and delegate the foot examination if you are very busy? The answer is, if your training method is good, the answer is yes. I think we should do this, because over a period of time you can't say I was busy, I did not examine the foot, because if you say that, the amputation happens and you are responsible for it, because the patient has come to you first and you have actually missed the diagnosis. Always remember, even Batman had Robin. You don't have to be a hero all the time. You can always have assistants to take care of it. So the conclusion is meticulous history taking regarding the foot problems, even if the patient is not talking. A thorough examination at each visit if possible. Check for vascularity and sensation so that you don't miss. A good foot care education and footwear advice. Empower your nurse educators. And this is the way to move forward with every patient that we have. Well, India is a difficult country, What works in IASC may not work outside, what works outside may not work in villages. So I think we need to kind of integrate things, because every 100 kilometers India changes, everything changes in India every 100 kilometers. So thank you very much, and thanks Sanjay, and thanks Pavan for giving me an opportunity. Thank you so very much.